Hey everyone, are you surviving those oxygenation chapters? I know it could feel like a lot, especially with labs and lectures and then clinicals all at the same time.
Oh,
But
yeah.
don't worry, we've got you covered. Today we're doing a deep dive into a couple of Professor Peller's resources.
Okay.
We've got her lab discussion document and her lecture presentation on oxygenation.
Sounds good.
So we're going to break it all down, make sure you're ready for those exams,
Wow.
and that you feel super confident and safe when you're actually working with patients.
I think this will be a good one. Oxygenation. It's kind of where it all comes together.
It really
You
is.
know, all that anatomy and physiology and then the patient care,
Yeah.
even a little bit of physics thrown in there.
Oh yeah, with those oxygen delivery devices.
Yeah, exactly.
Speaking of those devices, one of the first things Professor Peller talks about is safety.
Oh, for sure.
Right. I mean, even before you think about hooking up a nasal cannula or anything like that,
Uh-huh.
you got to make sure you're not about to accidentally start a fire.
That's so important. It's one of those things that even experienced nurses sometimes forget about.
Really?
Oh, yeah. Professor Peller mentions things like using oil-based lotions or hand creams in a room with supplemental oxygen.
Oh, right.
And it's easy to forget that even just a little spark, from static or something could ignite those oils.
Oh, wow, that's scary. So no scented candles burning in the patient's room?
Definitely not a good idea.
What about electronic devices? Are those safe to use around oxygen?
It's always best to err on the side of caution with that kind of thing.
Yeah,
Always check your facility's policy, but generally you want to avoid anything that could spark or overheat.
makes sense.
Professor Peller even mentions double-checking electrical equipment for frayed
Oh,
cords.
yeah.
Things like that, loose connections, anything that could cause a spark, basically.
So it's all about thinking ahead and being extra careful.
Exactly.
Definitely a good reminder for clinicals.
For sure.
And I bet that shows up on exams too.
Oh, absolutely. Speaking of exams, Professor Peller's materials go really in-depth about the different types of oxygen delivery systems,
Okay.
like low flow versus high flow.
Right.
Knowing the difference between those and when to use which one is key.
Okay, so let's break that down. I remember when I was first learning about this stuff, I was always confused about, what does low flow even mean? What does high flow mean?
Yeah.
It's not just about how much oxygen you're giving, is it?
Right. It's more about whether the oxygen flow from the device is enough to meet the patient's entire inspiratory need.
Okay.
So with low flow devices, think about your basic naval cannula.
Yeah.
They usually don't meet that full need. They deliver oxygen up to 15 liters per minute, but the patient's still breathing some room air.
Okay, so high flow is when the patient needs a more precise amount of oxygen.
Exactly. High flow systems like ventilators or some specialized masks provide enough flow to meet or even exceed the patient's inspiratory demand.
So that's where you would use it if their breathing isn't strong enough on their own.
Professor Peller really emphasizes that you need to know the flow rate ranges
Okay.
for the different devices and examples of each.
Okay.
So I bet you'll get an exam question that asks you, which of these is a high flow device, a nasal cannula or a non-rebreather mask?
Ooh, those are the kind of questions that really make you think. Okay, so we've got low flow and high flow, but then within each of those categories, there's even more different types of devices.
So many.
Right. Christopher Peller gives a good breakdown of each.
Yeah.
But where do you think we should focus for students who are getting ready for exams and clinicals?
I'd say start with the basics, like the nasal cannula.
Okay.
It's the most common one you'll see.
Oh, for sure.
But there's still a lot to know about it.
Okay.
Professor Peller mentions flow rates for low flow oxygen through a nasal cannula are typically 1 to 6 liters per minute.
Okay.
It's simple and easy to use, and it doesn't get in the way of talking or eating.
Right.
But it can dry out the nasal passages, and it can come loose kind of easily.
Yeah, patients always complain about that dryness.
Oh, yeah.
And those proms can be uncomfortable too if they're not in the right spot.
Yeah, absolutely.
So what about when a patient needs more oxygen than a nasal cannula can handle?
Then you might move up to a simple face mask,
Okay.
which can deliver a slightly higher oxygen concentration.
Okay.
But here's a key point for exams. The minimum flow rate for a simple face mask is 5 liters per minute.
Oh, wow. I remember that.
Anything lower, and you risk carbon dioxide building up.
That's a big deal. I bet that's a common exam question.
Oh, for sure. It's one of those things where they might try to trick you.
Yeah, they'll give you a flow rate below 5 liters and ask if it's okay to use with a simple face mask.
Exactly. You've got to be careful.
So it's not just about giving oxygen, it's also about making sure they're exhaling carbon dioxide.
Right.
I could see how mixing that up could be a serious problem.
Definitely. All right, so then if a patient needs even higher oxygen concentrations, then you move into those reservoir masks. Like the partial rebreather and the non-rebreather?
Oh, yeah, those are the ones with the bag, right? I always struggle with understanding those.
Yeah, they can be a little tricky at first.
All those valves.
Yeah, but the main difference is in the valves. The partial rebreather lets some of the exhaled air mix with the oxygen in the bag,
Uh-huh.
but the non-rebreather has valves that prevent that mixing.
Okay.
So basically, the non-rebreather delivers a much higher concentration of oxygen.
So it's like it's making sure they're only breathing in the pure oxygen
Right.
from the bag.
Okay.
I think those diagrams that Professor Peller has in her materials were really helpful for understanding those masks.
Oh, for sure. Visuals always help.
Yeah, I bet there might be a diagram labeling question on the exam
Oh, yeah, for sure.
about those masks.
Absolutely. All right, and let's not forget about the tracheostomy collar,
Okay.
which Professor Peller describes as delivering humidified oxygen
Okay.
directly to the trachea.
Okay.
Usually for patients who've had a tracheostomy.
Makes sense.
And the flow rate that she mentions is usually 8 to 10 liters per minute.
So that's a good point. It's not always just about masks when we're talking about oxygen delivery.
Right.
There's other ways to do it depending on what the patient needs.
For sure.
Okay, so we talked about safety, and we talked about all these different oxygen delivery devices.
Uh-huh.
But Professor Peller's materials also mention medications that can affect breathing.
Oh, yeah.
Right. I feel like that's a whole other topic we could deep dive into.
It is a whole other world, but it's really important because you need to understand how those meds work.
Right.
Just like you need to know how to deliver oxygen.
Yeah. So Professor Peller talks about meds like bronchodilators,
Right.
mucolytics, and corticosteroids.
Uh-huh.
Those are all super important for managing breathing problems.
Yeah. You'll definitely need to know the names and how they work and any side effects they might have for exams.
Okay.
For sure.
So like bronchodilators, I remember learning that those work by opening up the airways,
Right.
which is really helpful if someone's struggling to breathe.
Absolutely. And then mucolytics help thin out the mucus,
Oh, yeah.
so it's easier to cough up.
Okay.
But how are those PEDs actually given?
That's a good question. So Professor Peller describes a few different ways,
Okay.
like nebulizers,
Right.
MDIs, and DPIs.
Uh-huh.
And it's not just about knowing the names.
No.
You got to know how to use them properly.
And how to teach your patients to use them.
Oh, yeah.
Like with an MDI, Professor Peller talks about using a spacer
Oh, right.
to make sure the medicine actually gets down into the lungs.
Oh, yeah. Those spacers, they can be a little weird to use at first,
Yeah, a little checky.
but they do make a big difference.
Huge difference.
What's about rinsing after using inhaled corticosteroids?
Oh, that's super important.
Okay.
You have to do that to prevent thrush,
Oh, right.
which is a fungal infection that you can get in your mouth from those meds.
Okay.
So yeah, rinsing is a big part of patient education there.
It's all about those little details.
It really is.
That can make a big difference. Okay, speaking of little details, I have to ask about something that made me laugh when I was reading Professor Peller's stuff. The chicken dance.
Oh yeah, the chicken dance? Professor Peller's funny like that.
I know.
It's just her name for the huff cough,
Right.
which is a technique for coughing more effectively.
Right.
It might sound silly, but it's really helpful for patients who are trying to clear their airways,
Okay.
especially those with COPD.
I love that she makes it fun
Yeah.
and memorable.
Exact. Okay, so we covered safety and different devices for delivering oxygen and even some medications.
Uh-huh.
But to really get this stuff, you need to go deeper.
Yeah.
Right? Like into the anatomy and physiology behind it all.
Okay.
That's where Professor Peller's lecture on the respiratory and cardiovascular systems comes in.
That's the foundation for everything we've been talking about.
Exactly. It's all connected.
Oh, man, remember that fact about like the 25 sextillion molecules exchanged with each breath?
It's mind-blowing.
It's insane.
Yeah, and the way Professor Peller explains it all,
Yeah.
with those diagrams and everything.
Yeah, her visuals are amazing.
It's really clear how the little molecules travel from the lungs to the blood and all through the body.
Yeah. Okay, so to understand all that, we need to know some key terms that Professor Peller uses.
Oh, yeah, for sure.
Like pulmonary ventilation.
Right.
Respiration.
Uh-huh.
Perfusion.
Yeah.
Hypoxia.
Those are all important concepts. You're going to need to know those for your exams.
Oh, yeah, for sure. Like, be prepared for questions like, what are the early signs of hypoxia?
Definitely.
Or, why is perfusion so important?
Oh, yeah, you'll see those questions.
Yeah.
But it's not just about passing the exam.
Right.
It's about being able to actually assess your patients,
Yeah.
figure out what's wrong with them,
Yeah.
and then give them the right care.
Right. And that brings us to another big part of Professor Peller's lecture,
Okay.
nursing assessment. This is where everything we've talked about comes together.
Yeah, it's where the rubber meets the road.
Yeah.
You know, like you got to put on your detective hat.
Yeah.
You're using your eyes, your ears, your hands
Yeah.
to gather all the clues you can about how well your patient is breathing.
I remember being so overwhelmed at first
Oh, yeah.
by all the things you have to look for.
It's a lot to take in. So Professor Keller breaks it down into three main parts:
Okay.
inspection,
Okay.
palpation,
Uh-huh.
and auscultation.
Right.
Each of those gives you different information.
Okay.
And it's amazing what you can figure out just using your senses.
Like what kind of things that we're looking for when we inspect a patient?
Well, you're looking for any signs that they might be having trouble breathing.
Okay.
Like cyanosis, which is
Okay.
that bluish color to their skin,
Yeah.
or their lips and nail beds.
Okay.
That means they're not getting enough oxygen.
Oh, wow.
You also want to look for pallor, which is just paleness,
Okay.
and pay attention to how they're breathing.
Right.
Are they breathing fast? Are they using those muscles in their neck and chest to help them breathe?
So you really have to pay attention to their whole body, not just their lungs.
Exactly. And don't forget about inspecting their chest.
Oh, right.
Professor Peller mentions looking for any deformities, or if one side looks different than the other,
Huh.
or if their chest is moving in a weird way.
Okay.
Those could all be signs of breathing problems.
Wow, you can learn a lot just by looking.
It's true. And then there's palpation, which is all about using your hands to feel for more clues.
Okay.
Professor Peller walks you through how to feel for things like skin temperature chest expansion
Okay.
and tactile firmitis.
Alcohol-firmitis. What's that?
That's just the vibration you feel when the patient talks.
Oh, okay.
You also want to feel for any tenderness or lumps,
Right.
which could mean there's something else going on.
Okay, so palpation gives you even more information.
It does. And then there's auscultation, which is the fancy word for listening to lung sounds.
Oh, yeah.
That's where you get to use your stethoscope.
Okay, so for auscultation, that's where you really need to know those different lung sounds.
Right. Like Professor Peller talks about vesicular breath sounds,
Uh-huh.
which are soft and low-pitched.
Okay.
And you hear them mostly when the patient breathes in.
Okay.
And then there's bronchial breath sounds,
Okay.
which are louder and higher pitched.
Right.
And you hear those mainly over the trachea.
Okay, so those are the normal sounds.
Right. But then there are the abnormal sounds.
Oh, right, the adventitious breath sounds.
Exactly. And those can tell you that there's a problem in the airways.
Oh, okay.
Professor Peller describes crackles, which are those discontinuous popping sounds,
Okay.
often caused by fluid in the airways.
Right.
And wheezes, which are continuous musical sounds,
Yeah.
often caused by narrowed airways.
Okay, so being able to tell those sounds apart is really important.
Oh, it's crucial.
Because they can point to different problems.
Yeah, exactly. Crackles might make you think of pneumonia or heart failure,
Okay.
while wheezes might make you think of asthma or COPD.
Wow. It's like you're a detective trying to solve a mystery.
It's a great way to put it. And Professor Peller doesn't just stop there.
Oh, no.
She also covers other diagnostic tools like ECGs,
Oh,
pulmonary function tests,
Uh-huh.
the pulse oximetry, and ABGs.
Wow, we've covered a lot in this first part of our deep dive.
I know, right?
It's amazing how much information Professor Peller gives us.
She's awesome.
Yeah, she really is.
And it shows how important oxygenation is in nursing.
Oh, yeah, for sure. It's a complex process, but understanding it can really make a difference for our patients.
Absolutely. It can be the difference between life and death. All right, so let's get back to those oxygen delivery devices. We talked about some of the key ones in the first part of our deep dive, but now let's really get into the nitty-gritty, the details that'll help you on those exams and in clinicals.
Okay, sounds good. I'm ready for more. I feel like there's always more to learn about these devices, especially when it comes to those little things that can really make a difference for patients.
Oh, absolutely. It's those little things that can really trip you up sometimes. So let's start with the nasal cannula, the MVP of oxygen delivery. Professor Peller spends a lot of time on this seemingly simple device, and for good reason.
It's so basic that it's easy to forget about all the nuances. Like I remember in clinicals, even with a nasal cannula, there were things to watch out for, like making sure the prongs were in the right spot and that the tubing wasn't kinked or anything.
Those are great points. Professor Peller mentions that you can actually crank up the flow on a nasal cannula.
Really?
Yeah, you can go up to 6 liters per minute for low flow oxygen, and you can even go higher up to 15 liters per minute if you need to. But here's where you got to use your nursing brain. At those higher flows, you really have to watch out for patient discomfort and skin breakdown.
Yeah, that makes sense. I can imagine it would get pretty irritating to their nose at those higher flows. And if they're wearing it for a long time, you definitely don't want them getting sores, especially around their nose and ears.
Exactly. And that brings up another important point, humidification. Professor Peller really stresses that humidification is super important for patients who are on oxygen for a while, regardless of what kind of device they're using. That dry oxygen can really do a number on their mucous membranes.
Humidification is so easy to forget about in the chaos of clinicals. I bet that shows up on exams.
Oh, you know it does. Like, I wouldn't be surprised to see a question where they give you a scenario about a patient who's on a long-term oxygen therapy and they ask you to pick the right interventions.
Yeah.
And humidification would definitely be one of the answers. Okay, so moving on from the nasal cannula, let's talk about the simple face mask.
Okay, that's a step up from the nasal cannula in terms of how much oxygen you can deliver right. But I remember Professor Peller saying something about a minimum flow rate for this one.
You got it. This is a biggie for exams and also just for patient safety. Professor Peller emphasizes that the minimum flow rate for a simple face mask is 5 liters per minute. Anything lower, and you risk the patient not getting enough oxygen out.
Oh, wow.
Yeah, and then the carbon dioxide builds up.
So it's not just about delivering oxygen, it's about making sure they can get rid of the carbon dioxide too. I can see how forgetting that detail could be a big mistake.
Definitely. That's why it's so important to understand why we use each device the way we do. Okay, so what happens when you need to give even more oxygen than a simple face mask can handle? That's when you bring in the big guns.
Okay.
The reservoir masks. We're talking the partial rebreather and the non-rebreather.
Oh yeah, those are the ones with the bag, right? I remember struggling with these in class. It's hard to keep all those valves straight.
Yeah, they can definitely be confusing, but the main difference boils down to those valves. The partial rebreather has a valve that lets some of the exhaled air mix back in with the oxygen in the bag, but the non-rebreather has valves that stop that mixing from happening. So what does that mean? It means the non-rebreather delivers a much higher concentration of oxygen.
So it's all about making sure they're breathing in as much pure oxygen as possible. I think Professor Peller's diagrams of these masks in her materials were really helpful for understanding how those valves work.
Oh yeah, for sure. Visuals always help.
I could definitely see them putting one of those diagrams on the exam and asking us to label the different parts.
Oh, for sure. Or maybe they'll ask you to explain how the valves work or something. All right, now let's switch gears a bit and talk about the Venturi mask. You know, that one with the interchangeable barrels.
Oh yeah, that one always seemed a little intimidating to me. What's so special about the Venturi mask compared to the other ones?
The Venturi mask is all about precision. It uses those barrels, and each one is designed to deliver a very specific oxygen concentration. This is really important for patients with conditions like COPD, where giving them too much oxygen can actually be harmful.
Yeah, that always seems counterintuitive to me, that sometimes less oxygen is better. But it makes sense when you think about how the body works. So with the Venturi mask, you can really fine-tune how much oxygen they're getting.
Exactly. And Professor Peller will definitely have some exam questions testing you on those barrels and what oxygen concentration each one delivers. Like, imagine they give you a patient with COPD and the doctor orders a specific oxygen concentration. You need to know which barrel to use.
That's a good example of how knowing this stuff translates to real-life situations. It's not just about memorizing facts for a test. It's about making good decisions for your patients.
Exactly. All right, now before we move on to the wonderful world of nursing assessment, let's quickly touch on the tracheostomy collar again. Remember, that one's designed to deliver humidified oxygen directly to the trachea for patients who've had a tracheostomy.
Right, and I think Professor Peller said the flow rate for that is usually 8 to 10 liters per minute. It's a good reminder that there are other ways to give oxygen besides just masks.
Exactly. Okay, so now let's shift gears and talk about nursing assessment. This is where your detective skills really come in handy.
Okay.
You're using your eyes, your ears, your hands to gather all the information you can about how well your patient is breathing. Professor Peller has a whole section in her lecture on this, and it's super important.
Okay, so it's like we're putting on our detective hats, right? We're looking for clues about how well their respiratory system is working.
Exactly. You got it. Professor Peller walks you through the steps: inspection, palpation, and auscultation. And each step gives you valuable information. It's amazing what you can figure out just by using your senses.
I remember when I first started learning about this stuff, I was totally overwhelmed by all the things we had to look for.
Oh, yeah. It's a lot to take in. So when we're inspecting a patient, what are some key things Professor Peller tells us to focus on? Well, first, you want to look for any signs that they might be having trouble breathing.
Okay.
So things like cyanosis, that bluish color to their skin, especially around the lips and nail beds.
Right.
That's a big red flag that they're not getting enough oxygen. You also want to look for pallor, which is just paleness. And then pay attention to how they're breathing. Are they breathing really fast? Are they using those muscles in their neck and chest to help them breathe? Those are all signs that something might be wrong.
So we're not just looking at their lungs, we're looking at their whole body for clues.
You got it. And don't forget about inspecting their chest itself. Professor Peller talks about looking for any deformities or asymmetry, like if one side of their chest looks different than the other, or if their chest is moving in a weird way. Those could all be signs of breathing problems.
Wow. I never realized how much you could learn just by looking. Okay, so what about palpation? I remember struggling with that one a little bit, especially when it came to figuring out chest expansion.
Palpation is all about using your hands to feel for clues. Professor Peller teaches you how to assess things like skin temperature chest expansion, and tactile fremitus.
Tactile fremitus, what is that again?
It's just the vibration you feel when the patient is talking.
Oh, right, right.
You're also feeling for any tenderness or masses, which could be signs of other problems.
Okay, so palpation basically gives us more information on top of what we already got from inspecting the patient.
Exactly. And then we move on to auscultation, which is the fancy word for listening to lung sounds. This is where you get to use your stethoscope and really tune into what's going on inside those lungs.
I remember being both excited and kind of nervous to start doing this part of the assessment.
Yeah, it definitely takes practice, but it's so cool when you start to hear those subtle differences in lung sounds and you can actually figure out what they mean. Professor Peller does a great job of breaking down the different types of breath sounds, both normal and abnormal.
Right, like vesicular breath sounds are the normal ones you hear over most of the lungs. Right, they're soft and low-pitched, and you mostly hear them when the patient is breathing in.
You got it. And then there are bronchial breath sounds, which are louder and higher pitched, and you hear them mainly over the trachea. But then we have those abnormal breath sounds, the ones that tell us something's not quite right.
Right, the adventitious breath sounds. Professor Peller talks about crackles, which are those discontinuous popping sounds that you often hear when there's fluid in the airways. And then there are wheezes, those continuous musical sounds that you hear when the airways are narrowed.
Exactly. And being able to tell those sounds apart is super important because they can point to different problems. Like crackles might make you think of pneumonia or heart failure, while wheezes might make you think of asthma or COPD.
Wow. It's like we're putting together a puzzle trying to figure out what's going on with the patient's respiratory system.
That's a great way to think about it. And Professor Peller doesn't stop there. She also covers other diagnostic tools like pulmonary function test, pulse oximetry capnography, and ABGs. All of those can give us more information about how well the patient is breathing.
It's amazing how much we can learn about the respiratory system just by using these different assessment techniques and tests.
It really is. And it all comes down to being a good detective, using all the tools at your disposal to figure out what's going on with your patient.
All right, so we're back for the last part of our oxygenation deep dive, and I'm ready to tackle those other diagnostic tools Professor Peller talks about. I'm especially curious about pulmonary function tests, or PFTs. Those always sounded kind of mysterious to me.
I know what you mean. They sound intimidating, but really they're just clever ways to measure how well those lungs are working.
Okay.
Professor Peller breaks down a bunch of terms that might seem like a whole other language,
Right.
but they make sense once you know what they're measuring.
Okay, so break it down for us. What are some of the key terms we need to know?
Well, let's start with tidal volume.
Okay.
That's just the amount of air you breathe in and out when you're just breathing normally relaxed.
Okay.
Easy peasy, right?
Okay, yeah, that makes sense.
Then there's vital capacity,
Okay.
which is like the max amount of air you can breathe out after taking the deepest breath you can.
So tidal volume is everyday breathing, and vital capacity is like really pushing your lungs to the limit.
Yeah, exactly.
I could see how those measurements would be helpful for figuring out if there's a problem. What else does Professor Peller mention?
She talks about forced vital capacity,
Okay.
which is similar to vital capacity, but it measures how much air you can force out quickly.
Okay.
So it's like how much air can you blow out really fast.
Okay.
These tests can tell you a lot about what's going on in the lungs.
Okay.
Like they can help differentiate between restrictive lung diseases, where the lungs can't fully expand, and obstructive lung diseases,
Okay.
where airflow is limited.
Okay, so it helps you narrow down what kind of lung problem the patient might have.
Exactly. It's all about connecting those dots
Yeah.
from those physiology concepts to what you're seeing in the patient.
Right.
Because she also mentions peak expiratory flow rate, or PEFR.
Okay.
You probably used a peak flow meter in one of your labs.
Oh, yeah. It's that little handheld thing you blow into, right?
That's the one. It measures how fast you can blow air out. And Professor Peller says that people with asthma often use those at home to keep track of how they're doing.
Oh, that's right. I remember learning about that. It's cool how something so simple can tell you so much. Okay, so we've got all these lung function tests, but what about capnography? Professor Peller mentions that one too.
Oh, yeah, that's a cool one. It's a newer technology that's becoming more and more common in hospitals. It measures how much carbon dioxide is in your breath.
Okay.
It's really useful because it can tell you how well the patient is ventilating.
And it's non-invasive, right? You don't have to stick needles in anyone.
Nope, totally painless. It's great for monitoring patients during surgery or if they're in the ICU. Okay, now Professor Peller also talks about thoracentesis.
Okay.
That one's not a test, though.
Right, it's a procedure.
Yep, they stick a needle into the space around the lungs to drain fluid. They might do it to figure out what's causing the fluid buildup
Okay.
or to relieve pressure on the lungs.
That sounds like it's scary for the patient.
Yeah, it can be, but that's where nurses come in. We're there to explain things to the patient,
Right.
answer their questions, make them feel comfortable.
Okay, so we talked about some tests and even a procedure, but let's get back to those lab tests.
Okay.
Specifically, ABGs, arterial blood gases. Those give us really precise info about the oxygen and carbon dioxide and pH levels in the blood. It's like a snapshot of how well those lungs are working.
Right. And Professor Peller really emphasizes how important it is to be able to interpret those ABGs.
Uh-huh.
Because those results can really guide treatment decisions. Remember those key values, pH, PO2 for oxygen, PCO2 for carbon dioxide.
Oh, yeah.
Those numbers tell a whole story about what's going on inside the body.
It's like you got to crack the code to figure out what they mean. I remember struggling with that at first, but once it clicks, it's really helpful.
It's definitely one of those things you got to practice.
Yeah, for sure. Okay, so we've talked a lot about diagnosing problems, but what about preventing them? Professor Peller also talks about ways to promote good lung function.
Oh, yeah, that's a huge part of nursing. It's not just about fixing things when they're broken. It's about keeping people healthy in the first place.
So what kind of things does Professor Peller suggest?
Well, a lot of it comes down to patient education, teaching people how to take care of their lungs.
Okay.
So things like quitting smoking,
Yeah.
getting enough exercise,
Uh-huh.
and making sure they get their vaccines, especially for the flu and pneumonia.
Right.
Those are all important for preventing respiratory infections.
And what about those breathing techniques? I remember learning about deep breathing exercises and pursed lip breathing.
Oh, yeah, those can be really helpful.
Do they actually make a difference?
They can. Professor Peller explains that these techniques can help people breathe easier
Okay.
and even help with anxiety sometimes. And of course, we can't forget the chicken dance, that huff cough technique.
I love how she calls it the chicken dance.
Me too. It makes it so much more fun to teach.
Right. It's like you can make people laugh while you're teaching them important stuff.
Exactly. It's a good reminder that even small things can make a big difference for our patients. So as we wrap up this oxygenation deep dive, what are some of your main takeaways?
Wow, that's a good one. We've covered so much. We talked about all those different oxygen delivery devices,
Uh-huh.
how important safety is,
Right.
all the different ways to assess a patient's breathing,
Yep.
and even how to teach them to take care of their lungs. But I think the biggest takeaway for me is realizing that oxygenation isn't just some boring topic in a textbook.
Yeah, I agree.
It's like this crucial part of nursing care. We have to understand it inside and out, and then use that knowledge to really help our patients.
You said it. Professor Peller's stuff gives you a great foundation, but remember, learning never ends.
That's true.
Keep asking questions, keep learning, and never forget how much of an impact you can make as a nurse.
That's really inspiring. Thanks for taking us on this deep dive. It's been awesome.
My pleasure.
And to all you nursing students out there, keep studying hard. And remember to practice your chicken dance.